Hello, everyone. Welcome to CAAMSA Highlights in Medicine. My name is Mohammed Ali, and today we are fortunate to have Dr. Slomka. Dr. Slomka is a highly decorated scientist, currently a professor of medicine and cardiology at Cedars-Sinai and University of California in Los Angeles. And Dr. Slomka also actually completed a PhD in the field of radiology and cardiac imaging in University of Western Ontario, and he also runs his lab in Los Angeles as well. So he has a lot of accomplishments and articles in the application of MRI, radiology, and the use of artificial intelligence in diagnostics as related to the field of cardiology and heart imaging. And we decided to have these events for the most part because AI is playing a very vital role in our current society and also in field of medicine. There's been a huge amount of movement toward inclusion of AI in the field of medicine, more so in the field of diagnostics. And especially within the past 30 years, out of the 521 submissions to the FDA, almost 3/4 of them were related to radiology and 11% to cardiology. So it's a field that is emerging, and it's good for our audience and everyone in the field of medicine to get to know this field better. And that's why we invited one of the key opinion leaders in the field to talk about their research and let us know about their amazing journey and current research and see what we can learn from them. So without further ado, I want to give the spotlight to Dr. Slomka. Thank you so much for being here, Dr. Slomka.
Thank you very much. I will, do you want my video on or off? Like, what do you prefer?
Whatever you prefer.
Yeah, okay. So I will, let me just share my screen here with you. Second. So share. Okay. You can see my screen well?
Yes, we can.
Yeah. Okay. So thank you for inviting me to your seminar. It's a great honor to present to your group. I will talk to you today about things we are doing here. It's AI in cardiac imaging, and there'll be some general issues regarding AI, which I think will apply to, in general, to AI in medicine and so forth. But this is our field, AI in cardiac imaging, and I'll show you the kind of things we're doing. These are my disclosures and funding. This is Los Angeles, Cedars-Sinai, where I work is somewhere around here. We have a lot of rain, so there's this kind of situation now here. But sky is looking nice now. These are my collaborators where we work on these topics together. We work with a lot of physicians and sites who provide data and collaborate with us on some of those projects. This is our research team. Most of it is on Zoom right now. We're transitioning to in-person now. So in general, any kind of AI project will have to start with the data. And I will talk about this AI here in this kind of topics. First, I like to describe the data, how we collect the data, how we clean the data. Then we'll talk about the automated quantification of images. We mostly do deep learning. Then I'll show you an example how we actually improve images, and that's one of the kind of applications. And then some more challenging applications where we actually diagnose patients or predict risk, and that will apply, I think, to any kind of AI in medicine, those topics. So first, I like to describe to you the technology, the kind of specific medical specialty we work with, which we apply these techniques. And then we will be talking about the nuclear cardiology, but also CT. That particular modality is well established. In United States, we perform 7 million scans per year. Worldwide, 15-20 million. So this is a well-established modality where you image the heart of the patient while they're stressing, during stress, and then during rest. And you look at the blood perfusion in the heart. You see, how the heart muscle functions. You can look at the function of the heart. You can get things like ejection fraction, which you typically get with ultrasound. And you can also look at the blood flow, dynamic blood flow, but you also have CT. Very often we have these hybrid scanners where we have a CT, where this is more like anatomical images. The nice thing about the application of AI here is that all these images are digital, and it's all available, and it's all three-dimensional, and we already do some quantification. So physicians is tasked with understanding the patient based on all these different variables and clinical variables and imaging variables. And here we can show how AI can be applied and can be beneficial. So the first thing, the project we started was we call it Refine SPECT. This project, so the technology is called single photon emission computed tomography. That's a particular modality. We try to combine a lot of data, and actually it turns out this is a big effort. This job is actually taking a lot of our efforts to clean the data, to make data usable for the algorithms to be trained. And that in medicine, I think that's something very common. The data are difficult to get, data protected. We have to de-identify all the data. There's a lot of agreements we have to sign with the sites. It's not open like in other fields. So I think that is one difficulty. As you can see, the task is difficult. So we, in that project, the first project we started a few years ago, and that was an original article where we described this registry. We call it the registry of the data, where the sites are contributing the data. At that time, we managed to collect 20,400 patients. 17 cases were excluded due to some missing data, but we had a pretty nice clean data. All this data, in all this data set, we had actual events, what happened to the patient. MACE means major adverse cardiac events. That's a heart attack, basically death, and some other serious events for the patient. You can imagine if you have images and then you follow the patient up, then you have events, then you can maybe try to predict this event, so you have a sort of full picture going backwards. So we're not prospectively testing this, but we can retrospectively see what happened with these patients based on the images they had, like, for example, 5 years before. And this is how we collect the data in this kind of registry. We collect information. So for the AI system, for a medical system to work, we need to have some clinical information, like past medical history of the patient. For example, stress test results, how the patient, exercised during stress, clinical interpretation, and then the outcomes. We call them the all-cause mortality, heart attacks, and some other outcomes here. So this is kind of the data you would need to collect to have a full information. Then you have images. So you have images here like CT. You will have this myocardial perfusion imaging. And those images have to be de-identified and cleaned and verified that they correctly agree with all this clinical information. And that's what we did in this core laboratory. This was a lot of work to put it all together. And then once we have that kind of database, a lot of the experiments I show you, the kind of AI techniques we do, is based on this data set, and we create some other data set. There are other data sets available, but it's difficult to come by in medicine, in general, or in imaging even more, because in imaging, the formats of the data are very specific, and a proper de-identification is sometimes very difficult. For example, someone could recognize a patient from the CT scan somehow. So this is kind of becoming a difficult issue. So right now in our set, we have about 47,000 cases. There's a few thousand still ongoing cleaning. This two sets here, the cleaning is ongoing, but it's not as much data like physically as you think. Actually, 40,000 cases would fit maybe on a, in this kind of set will fit like in less than 8 terabyte disk. So it can fit on a removable disk drive. It's not a lot of data, but it's a lot of effort to get this data together. So we managed to publish some papers with this, and the yellow ones are the AI papers, and I will be describing some of those techniques, which we show you how AI can be applied here. And in last year, you see this mostly AI we publish on this. So we also we have another modality, a little more difficult modality. We started PET imaging, and this is an ongoing new project where we will have 16 sites, and they will have like a positron emission tomography data starting now. So we'll just keep collecting this data because this is essential for all this project. But let me then describe to you what kind of things we can do in automated quantification with AI. So first of all is that we apply deep learning techniques. So for you, probably you're very familiar with these techniques, but let me just give you like a little bit like our take, how we look at it. We can detect, and as we know, deep learning is applied to images, for example, for detection of objects such as pedestrians for the autonomous driving, or faces on Facebook images and so forth. But we will apply it here to detect maybe disease. And so, for example, so that the networks will be going through these multiple layers, and at the end there will be some probability matrix for different, let's say, or maybe this is just one disease, so it'll be just one probability given for a disease. At the end, this is the outcome of the network. The other possibility is that you can segment images, and this is what I will first show you, is how we actually quantify segment images. And in this case, the deep neural networks will be in this kind of U shape. They call them U nets, and there's a variety of them, where images gets transformed through different layers, and at the end then it gets transformed back. And in this case, we're trying to fit the network weights. So the segmented image will correspond to the actual image, and if you feed enough of these pairs, you can train the network so it will then segment new images without having these labels. We call those segmented images, we call them labels. Or we can also transform images, a little bit similar, but we don't have to segment, but we can transform images into something different. And this is an example from a cycle gun, where this is video industry applications where you can transform images from a horse to a zebra, but we will apply it in medicine to medical images. So first I'll try with we'll show you with the application with a non-contrast CT. So CT is an anatomical modality where you look at these vessels of the in the body, and you try to look at these calcifications. And it is a very tedious process to try to quantify these calcifications and kind of find where they are. Are they in the heart or outside the heart? And this is very useful information. Scan is very simple, and we can perhaps do it with this kind of automated tools. So in this publication, we use a convolutional network called short-term memory network, which is scrolling through the slices. It's sort of looking at the slices in 2D, but it's scrolling through them as a radiologist and remembers the slices before and after. And because of that, is able to, very quickly go through the images, doesn't have to have this whole 3D image. So the memory it's very efficient memory-wise. And here you see the examples of the automated segmentation by that kind of network. And this is a manual segmentation by the expert who is pinpointing these calcifications in the arteries of the heart. And then when we compare the performance, so how do you compare performance of a network like that? We would compare it to the expert reader, we will look at and we often compare in this kind of clinical categories. So for example, reader says it's a low calcification and the network says low calcification. So this is like a broad comparison. And that is what clinically is useful, because this is what they use these categories to assign risk to the patient. So if everything is on the diagonal here, that means is a good performance. And here we tried it on a very kind of high quality scans. We call them gated scans, where the heart is gated. So you have this like a picture snapshot of the heart in a particular heart cycle. But we very often acquire like not super accurate scans, but they are very cheap, and they are kind of coming like for free almost they call them CT attenuation scans. And we show that actually on those scans, computer can also detect very well this calcium. And then there were some other external scans. This was published in a SPI meeting 2022 last year. So then we went on, and with this kind of techniques, we can apply it to like a larger cohorts, because in AI, I think there's two very important things, is that the cohorts you train on should be large, and so you have a lot of different patients. And the other important thing is that what you show that it works, you have to show in some external site. So it will apply to any concept, anything you do, that any data you develop some system AI in medicine, but you have to show it in some other hospital that it actually works. So because we have the data from these multiple sites, we're able to build the system from 2 sites and then try it in a different site. And then it's like a true validation that the system works. And here we apply this kind of deep learning calcium scoring, and we show that that agreement with the expert on the diagonal is very good for those very low quality scans. Those are very low quality CT scans. Still is able to segment the calcium. Expert reader, this is the deep learning, is able to do it. And we then look at these curves. Those curves, we call them Kaplan-Meier curves. What you see here is, does that computer generated risk, or this computer-generated segmentation of the calcium, does it actually translate into the outcome of the patient? So we're not talking about just some segmentation, how well this segments, how well it agrees with the reader. We're going further all the way to actual heart attacks, and we just want to see if that deep learning segmentation is actually useful. And you can see here that people who had low calcium score by the deep learning had a low event. So like these people, like this is the survival rate. So if you go here down, the green curve is kind of, these people are not, they don't have many events over 5 years. The people who have calcium score as found by the deep learning computer within about 2 seconds, this takes about 2 seconds. These people already, you can see that there's this decrease in the survival. And then the people who have higher and higher scores, they have less and less survival. So you can see that so we're trying to show not just some dice coefficients or some technical parameters, but actually some clinical parameters which clinicians can use. And here is another study related to this, where we've shown that the issue is in that we have this very high quality scans, carrier gated for this calcium scanning. But those scans have to be acquired separately. So it means that you have to do additional scan. Now, typically with a PET scan, you acquire the CT attenuation scans, which are very poor quality like this. But they're there by default. You don't have to do anything. You have the scans. So the question is, can the computer, and the physicians don't want to score scans like that because it's too noisy, too difficult. They want to scan these scans, but that means additional radiation to the patient and those. And time and cost, of course. So we actually tried to see, we had 2,737 patients where we had both scans, and we wanted to see how the expert reader on this very high quality scans, how that compares in terms of this patient, how many heart attacks the patients will have and how many of them will die, compared to this very low quality scans and run by the computer in a deep learning mode. And this inference was taking about 2 seconds per patient. Was trained on 6,000 cases from different sites. And you can see this survival curves look very vertically identical. So what this tells you is that possibly with deep learning, with AI, you could apply this kind of segmentations of very low quality images very fast, bypassing the need for this additional extra, high quality scan. So this will be the way to save money and cost using AI in medicine, to basically have some information extracted from a simpler image, or like a less complicated image or something which is already available, and not trying to get another image acquired. So now for the heart segmentation, there's other things you can do. And for example, here is a typical application where it's very useful to apply AI, because researchers have found that this fat, we call it epicardial fat, which is inside this pericardial sac around the heart, is a very important parameter. And the CT scans, as we have been saying, they are very simple to obtain, and they're there. And it's actually possible if you very carefully draw the lines on every slice. There's in this kind of simple scans, there's 47 slices. So you can imagine if you draw this line, 47 slices, then the computer somehow can threshold this pericardium and find that fat, and then add all the slices together, you get a volume of the fat. It would take typically 10 to 30 minutes per case for someone experienced to do this. And we can actually, just like we show in the calcium, we can automate this and find these volumes here in pink, the epicardial fat quantitation found in pink, just like expert will do, but that will take only 20 seconds on a GPU. So because we can do it, we actually can have a new parameter given to the physician, which they have never had because it was just too long to do. So that would be an application that you can extract something from the data, which just was taking too long to do before. Some new parameter like this epicardial fat. So I want to talk a little bit about a little bit more advanced CT, because that is taking now, it's like an anatomical CT, which is taking now a lot of interest, and it's sort of like another heart modality. And I show you how this segmenting can be done. It's very rapidly growing modality. It grew in the United States about 84% in the last 10 years, and it's going to be growing since quite a lot still. So what you see here is the actual, so these images are also CT images, but then the contrast is injected to the patient. You see the arteries here, and you see these plaques, this dark area here. So the white area here, that's calcium, like you saw on those regular images. This other image is non-contrast. That's pretty easy. But it turns out that that black area, it's called non-calcified plaque. The plaque, which maybe will calcify in the future, that plaque is actually very dangerous because it can cause it can really cause heart attacks, and it can cause that they can detach and cause blockages and so forth. So we will, but it's extremely difficult to do because you see how this arteries are very tortuous. Now this slice is about 0.5 millimeter each. So now you're talking about 500 slices going through these vessels, and now you're looking for these plaques, kind of like they look very close to the background. So this task is very difficult for the physician to do. So going about this plaque, this is work from Dr. Dave from our hospital. We can apply deep learning, similar algorithm like this long short term memory networks, which I've shown you. We can apply to segment and find this. You can find this plaques slice by slice and then display them in this fashion in 2D. You can rotate it. This is like this is a cross section here. You see, this is a cross section of like at this level here. So you have this like maybe 100 tiny slices, and the computer upsamples is like 0.3 millimeter. So that kind of job to do this accurately by a physician would take hours to do, because now you have many vessels and so forth. And in this publication in Lancet Digital Health, Dr. Lin and Dr. Manral, actually Dr. Lin is from Australia. He was a cardiac fellow in our institute working on this, show how this deep learning enabled CT angiography can be used for multiple applications. Now this shows like an overview of this paper, and you can see how much this medical AI needs, how much validation it needs. So first of all, this system was developed from 11 sites, and you can see Australia is also included here. Once you develop a system like that, different scanners, different protocols, different images, then is external validated in some other sites which are not participated in this development. Then how you evaluate? So you can look at the expert analysis, how the expert will do it for this hours versus computer. Then you can compare to some other modality, like in this case we have this intravascular ultrasound, which is an invasive ultrasound probe which goes inside the vessel and measures this, compared to this. Then you compare like the grading of the imaging cardiologist, and then you can also assess this prognostic value, we call it, which is the risk prediction, just like I showed you on this other slide. So all these things together, then eventually people believe that it maybe is useful. So this is the validation is key. And here are some results. So here you see this plaques. Here you see this plaque on a vessel, typically segmented. The red area is this non-calcified plaque. The yellow is the calcified plaque. Computer automatically found this in 3D. This is correlation with the expert. This is the correlation with the invasive ultrasound. So you look how this deep learning AI performs. These are these curves, you're sort of agreeing in the categories with the expert, just like in this calcium scans. This is for the stenosis or versus invasive standards. So you look at these agreements in categories, and then you also look at this prognostic value. In this case, what we have done here is there was another clinical trial, Scott-Hart, which was not related to deep learning, but we reprocess all the images with this deep learning algorithm, and there's like many different sites there, and it shows that this fully automated processing with deep learning, where you segment how big the plaque is in millimeters, cubic millimeters, about 240 cubic millimeters. When you have that threshold, you see that people who have heart attacks, myocardial infarction is a heart attack, 7 times higher chance for the people who have that higher threshold for the plaque. This is all automatically deep learning derived value, but then it's validated medically, like in this kind of way. So this is how you can show this is useful. So now I just want to go a little bit into the, how we can improve images. So I show you an example. So this was about how we quantify, how we segment, but then I showed you also how we validate this to make sure it's correct. But there are some applications where you can improve images. So this is a paper from Computer Science from 2019, where they show this technique, or GAN, or generative adversarial networks, which you're probably familiar with. In this application, it's kind of an example of adversarial training. So what we are showing is that what they are showing, this people who publish this, is that by having one image of a person and having a marionette here, you can generate a video, and the marionette can be given some text and we're speaking. So the movement of the eyes and the mouth will be, following some script. You can pretty much make a video of the person saying things which maybe they will not want to say, which could be very dangerous, as you can imagine. So this network is like a generator. So it's like a similar, like this, maybe this UNets, where it just generates its new images. But then we can actually have a ground truth, like the actual video of the person when we train this. Then we have another network, which is called discriminator. That network is tasked to compare the actual video with that deep fake video and try to find the difference. So now these two networks work against each other. That's why we call it adversarial. The generator is generating as good videos, these deepfake videos, as possible, and the discriminator is trying to detect if there's any difference between what the actual video is versus the deepfake video. And that's what is called adversarial training. So how can this be used in medicine and medical imaging? So we have this, and this is kind of explaining the technology a little bit here. We have this scans where we look at this heart muscle and the blood flow here, and we have a CT scan. They come from this hybrid scanner, SPET CT scan. So the hybrid scanner is acquiring it is like this. We need that CT scan to correct for attenuation to get like better image because when we image the heart with these photons, the photons are coming out, and when they are like far away in the body, we lose the signal. So for this, we use the CT to correct, to know where we are in the body, then we can correct it and make like a more corrected image. So but those systems with the CT are very expensive. This is what you really need to have. But actually in this particular configuration, maybe only 5% of the systems out there have the CT. And most system people use that, they don't have it. So is it possible to somehow generate images which are attenuation corrected without this CT? So we actually use this adversarial network for this. So in here, we have this NC is not corrected images. We generated, we had a network of about 5,000 images where we have both corrected and not corrected images with the CT, where we actually had the CT. We use this generator to then generate images as close as possible to this AC images. But then the discriminator will try to distinguish between this deep AC, the fake corrected versus the actually corrected images. That this deep AC images, they did not require to have CT. So that is how it works. This was a GAN with attention. And now again, the validation, as I said, in medicine is very important that you show that it actually works somewhere not in your institution. So we then collected data from 2 other sites which are not related to the sites where we generated this. And in that data, we had this special standard for the CTA where we actually knew what the disease was from another modality. In 600 cases, we've shown that if you, apply this proper attenuation correction with CT, you get area under the curve for prediction of the disease based on this other modality, the blue. If you do this deep AC, this correction based on this GAN, you get slightly lower, but it's not significant by p-value. But if you don't do any correction, this, I remind you, this is what most people use today in most hospitals. They will use this, what the red curve is. You don't get such a high accuracy. And both this true attenuation correction or this deep attenuation correction were superior to not doing it at all. So here's an example of trying to apply GANs to improve the image quality in some sense, or transform images to get better accuracy. Here's actual images. So these images look a little bit like this. This is the non-corrected image, and you see here that base, that part is deep in the heart, in the body, is kind of like has less photons. This is corrected by the attenuation correction with the CT. This is corrected by the computer with the deep learning. This is the difference between corrected and non-corrected. We call it a polar map. It's like a map of the heart, and you see the differences here. Then the difference between attenuation corrected and computer corrected by the deep learning is very small. Here's like kind of a, you see it in 3D. So another example in women. So we had to show, does it work in women? Does it work in males? Because those are the kind of issues people have in medicine. And here, and also, does it work in abnormal cases? Because abnormal cases, when there's like, here is a very abnormal uptake, and that abnormal uptake still preserved after attenuation correction, and here is still preserved after this deep AC. So when you validate anything in medicine, you have to show it works in normals, works in abnormals. You have to care about the population and so forth. So now I like to move to something maybe more challenging and maybe not yet so prevalent, but something which maybe is even more rewarding in the long term in AI application. And that is that computer can actually diagnose, because right now what we talked about is just quantifying, segmenting, improving images, but can actually AI diagnose conditions and help physicians in that regard? So in this manuscript, Yuka Odaki and Anya Singh, we've shown that deep learning can be indeed, so this is more like a detection problem where we have this images of the heart, these polar maps, and we try to detect coronary artery disease as defined by invasive angiography. So here we don't transform images, but we'll give a probability of the disease. And here the output from this will be the probability of the CAD, meaning coronary artery disease. And then we can give a probability in each vessel. And then we can actually show it in a segment. And I'll explain to you how we do this, because we use this attention maps to show where the computer is finding the diagnosis from. So looking at the graphs here in validations in 2,884 patients, we've shown that kind of computer-aided diagnosis, detecting of coronary disease, we get about 4% increase in accuracy over the current quantitative schemes, or the visual, and maybe 3% over the visual expert readers. So this may seem like a small increase, but this accuracy can never be 100%, because this is accuracy against some invasive coronary standards. So probably in the best case scenario, it could be maybe 85 or something percent. And here we're getting like 80, maybe 90, I don't know, but it's never gonna be 100. So we're moving this ROC curve quite a bit against some invasive standard. And here we show, in external testing, the same results. And this graph we often show in AI, in medicine, to show not the performance like diagnostic detection, but we call it a calibration. And what it means is that if the probability of the disease is given, if the computer gives 90% of the probability of the disease, we want to know that it's truly 90% probability that these people with this score actually have 90% chance of having disease. And then you can plot it over the deciles of the disease here, and you get this kind of called calibration graph, where the computer probabilities are in blue, and the actual observed event rates in this for those kind of deep learning scores are very close. You see, so if the red curve follows this the blue bars, that means it's well calibrated. The score we use for that is called Breyer score, which kind of describes you this probability. So if you're talking only about diagnosis, you may just cut off at some point and you just say above 50%, and you call it abnormal, or that cutoff point can be wherever, because it depends what the value is for you. Sometimes the cutoff point is much lower or much higher. But if you want to know across the whole spectrum, does your probabilities reflect the predicted probability, then you need a Breyer score or calibration. So let's talk about these attention maps for a second. So this is the technique we use is called GradCAM, and this comes again from the computer science. So Selvarahu et al. Has shown that you can apply this technique to any kind of neural network, any CNN, where you can backpropagate this, this findings back onto the images to show which part of the image is driving the prediction. That, for example, in this case, what they're showing is that, predict that there's a dog on the image, and that the network will propagate back on the face of the dog to show you that is what is driving the prediction. So we actually use this technique, and we use these polar maps, and we propagate back this finding of the coronary disease. We propagate on the polar maps to show that we can to localize. And you can see there's like this abnormalities here on this polar maps here. And that is where indeed the GradCAMs are indeed showing these areas as responsible for the prediction. In this paper, the issue comes up bias, because if you have and that when you deploy any AI systems in medicine, you'll have an issue with, does it work in women or men, for example, as well. So we found that, for example, here we were that system which was used to train this network for prediction had a lot of abnormals, because it was validated by this invasive angiography. By default, they have maybe 70% abnormals. But when you get patients in the hospital, only maybe 30% or 20% are abnormal. So you have this mismatch of what you train it on versus what you apply it to. And that is a significant problem. So you can use something called data augmentation, where you can actually generate more cases, more examples of the data you expect more in real life. And we did this augmentation where we added patients like more normal patients. And then we actually tested because women are sometimes very different in that, how the software that detects the disease. And we found that before we actually do this augmentation, we had this overestimation of disease. So the computer score was always coming like 20, 27, 20, 30%, when the probabilities were lower here. Actual disease prevalence was lower. So because we didn't have enough of these normal cases, maybe in women also, and because of this, once we started to add this more normal cases, we find these Breyer scores were going down, especially in women, and we're studying this some more. And of course, if you diagnostically want to detect, it didn't matter because they could all be classified as normal. But if you want to give the actual probability of disease for someone, then you need to watch these Breyer scores, and you need to see if you're well calibrated, and you can use this data augmentation to help you. Here's a clinical example of this, where the system is finding disease, 88%, and it's true, had this 85% stenosis by invasive standards, so it was confirmed. And here you have the map and the GradCAM showing you on the image, there's like this little area here that the GradCAM is pointing out to that area. So this is what we use. But in clinic or in medicine, AI will never be used standalone. It will be used together with a physician, or physician will be like the final, will be writing the report. So what you need to really test is to show that it actually works. The physician improves with AI, because it's not going to be AI itself. So we deploy this network, and we have an example, and then we train the physicians how to use it. And then we gave them the task. We gave them the 240 cases to read, where they were first reading them without AI, and then after that they were reading them together with the AI, and they try to see how it affects the reading. They were giving all the same results here and the same results here plus this extra result. And so what happened was that when they were reading, we had 3 different physicians. They're both board certified, experienced physicians reading this. What we found is that, you know, each of them improved numerically over what was possible, but it different to different extent. Different physicians improved differently. So this physician believed in AI and he really liked the results. He thought it was useful. He still used his judgment in the totality, but he was improving both sensitivity and specificity compared to result without AI. The one here, you know, the darker colors are with AI, and the kind of more blend colors are without AI. And you can see that this physician only improved where the AI was showing there's no defect, and he kind of confirmed, okay, this is a false positive, so he would just call it normal. So he was like a normal case believer. But this physician, it was still improving, but just was not trusting this AI too much. So you can see there is an issue, and this was AI on its own. So when this AI in medicine systems are deployed, they will be used with the physician, and the physician will be the final judge, and you will have to, there will be this bias and psychology involved, or how AI helps the physician and how the physician believes in it, and so forth. I think more training, would be useful here. Here's an example, like a clinical example. So I quickly go through, but here's like the kind of scans they look at, and you know, it's kind of, this is kind of a very difficult case. It's not easy to see if it's normal or abnormal. You see different in color and so forth, looking at the SPECT images, just going kind of quickly. But AI is finding a lot of, AI is finding a lot of abnormality here in this polar maps. And if you look at this, like a little bit kind of, you know, there's something here not quite right. But that was not first read as that was first read as a normal case by the physician. But then, you know, after one physician actually changed their opinion, and that actually was a truly abnormal case. So this is kind of a clinical deployment of the system. So why these attention maps are very important? So this is a study from PLOS Medicine, which shows the application of detection of pneumonia from X-rays, something different, but they use also attention maps. But in this case, pneumonia was shown in the shoulder, as the system was giving a very high probability of pneumonia, and it was in the shoulder. So even we don't work as physicians, but we know pneumonia is in the lungs. So something is very wrong. So that's how these maps can be used to show something's wrong. In this case, what was happening, that system, they had a special tag from a hospital, which had the hospital had a metal tag there, and that hospital had a very high incidence of pneumonia. So the AI was trying to cheat and kind of bypass it and say, okay, so use something in the data which could never be used for diagnosis, of course. But this is how it can be very tricky. So if you deploy this thing, it will apply to any kind of AI medicine application where, you know, you have to understand what the system is doing, because you will have situations like that, and there could be artifacts, there could be things something special in the data which is not related to the disease, but system is trying to take some shortcuts. So another application would be like a prognostic application, where you try to predict risk by AI. And in this case, this is Lin-Chin who published it in our lab. We show that you can do stress scan and rest scan. You have to do stress scan and rest scan when we do these heart scans. But if the stress scan is normal, if perfectly normal, there's really no need to do the rest scan. But to tell that it's truly normal is tricky business, and it's something physician has to judge, and to decide about the stress and rest, you have to do it right away at that time. So AI can perhaps help you to kind of quickly decide something is normal, so has a very low risk in this case of heart attacks. And we try to compare it with the physicians, and they're like different, and people publish in the medical literature to, you know, when to cancel the REST scan, because actually you can cancel 60% of the scans. So you can see it can save a lot of money potentially if you have a very good way to streamline and save it and cancel the scans immediately. And here you have AI system, which is, this is like a standard XGBoost system. It wasn't deep learning in that case, based on images. You can have many thresholds corresponding to some published clinical thresholds, and they will always have a higher sensitivity and specificity for performance for detecting of events. So you can look at the reclassification, and you can say, decide that you have 60% of patients you want to cancel, and you accept some risk, but you want to cancel 60% of your scans, and you want to know exactly quickly that they are normal. So if you take physician diagnosis, they're normal, just that, versus AI, and if you cancel 60% of scans, you will get this Kaplan-Meier curves where the blue is the normal, the red is abnormal. Of course, the abnormal will have a lower survival, but if you use AI, you see that the blue is higher and the red is lower. That means it separates it better. And so there's a different 60% of the patient. AI will be canceling some other selection of patients, but it will do a better job in finding who actually doesn't need it. And if you look at the over like a risk, the visually that these people will have 2% chance of heart attacks or these events or annually, and if it's selected by AI, it was going to be only 1.4%. And but you still achieve the same economic advantage of having 60% scans canceled, but that's safer way. The other issue would be, for example, can we like reduce the number of variables we use in AI? And that again applies to many fields, because we don't want systems overly complicated. People say if it's too many variables, we can't get these variables. Maybe they're missing. It's not very reliable. So in this paper, Richard Rios, we have from our lab, we've shown that you can look at this importance graph to see which variables are important, and then you can calculate AUC starting from here, where you have only some of these variables, and then you can keep adding these variables and see how much they actually improve accuracy. So let's say if you have 100 variables, it turns out that only first 10 or 12 variables actually improve accuracy. Then you can still start adding more and more variables to this AI system, but it just plateaus. The accuracy doesn't go. And this is the light blue is the confidence limit. So you can see at some point here, like probably 8 variables, you're like within the confidence limits what that system would do with 100 variables. So you want to perhaps have this parsimonious system with very few variables, because then you can understand that better, and you can explain to the physician better what it's caused, and maybe simpler to obtain this variable. Because in medical AI, sometimes it's a problem to obtain reliable variables quickly. So if you just focus on a very few key variables, it may be much easier to do. But you can also explain to physician, not just with the GradCAMS, but you can explain, and that standard classical algorithms have this built-in techniques, for example, XGBoost, that it tells you which features are driving the prediction for particular case. So that the individual weights can be shown here, and you can see here that in this case, the risk is up-risking, the diabetes for that patient is up-risking, the age is low, so it's de-risking, and then some other clinical variables are up-risking. So you can show to the clinician this kind of waterfall graph, and at the end you show, okay, well, the overall risk is high. The red line here is like where you call it low risk and maybe cancel risk scan. So for that patient, you can immediately see, okay, 10 variables which are driving the risk, and you understand the whole situation. So that possibly is a way to explain to physicians so they are in the loop and they feel they know what the AI is doing. Another example here from the medical world is that we sometimes have 2 different variables, very key variables, like the perfusion and flow. This is from PET. And people try for many years. They have published papers, that you try to combine this in this kind of graphs, when they say, okay, well, this kind of, if you have a low flow in the first tertile and a high perfusion defect, your risk is so much. So AI can be used for that. In this publication, we show that by this deep learning and from the images, we can directly predict risk, not just of the disease, but actual event, in this case, the death. So we can predict death directly from the image. and show on this GradCam where the patient, where the danger is, where the dangerous part on the image. And then we use this, that dotted line is the standard predictions, and that the solid lines are the ones created by the deep learning to show you, that you can predict better. This is NRI, is like a net reclassification index, is how many get reclassified more correctly. And you can see that you can separate these patients much better. Here's an example of that. A patient had an event in 3 months, and the system is showing you that the part of the image which is potentially responsible for this event. And this is kind of showing how you reclassify this high score and low score. So you can have this. The gray one is a standard what physicians are using right now. Ischemia is one of these variables which is used in many medical publications, but we can have a deep learning score, and we can see that we can separate this patient better for the risk. Or this flow variables, this is a new variable, people talk about it, the clinicians talk about it, but if you use this flow and this perfusion together, this AI score will be better separating still this patient into high risk and low risk. So in summary, what I would say that very well characterized data is essential for AI training on any kind of medical application, and it's sometimes a very challenging task, and that's probably taking most of the work we have to do. And I think something where AI in medicine will come first is where you have to do this very automate this very mundane task, like this calcium scoring. It can be done, physician can do it, but it takes time. It's very boring. And then it's also maybe 2 physicians will do it differently. We can also potentially improve image quality. I'll show you one example. There's many examples people work on this, but you can improve image quality. And you can assess diagnosis and diagnose and also predict risk from the images, but MD will be always in the loop, will have the final say. And AI can integrate multiple variables to predict outcome and also explain it to you. Thank you very much.
Thank you so much, Professor Slomka. That was very fascinating. I think I really appreciate it. So I have a couple of questions that I think my colleague Jordan will have some as well, but I would like to start with a question that probably you've been asked a lot until here when dealing with the clinician, and it's the fact that because there are a lot of articles coming in that the AI scored like it passed the USMLE in a fraction of seconds, and there's competition that hundreds of radiologists compete against an AI. It is almost in favor of AI. So in the future, do you see that the radiology is becoming a dying profession and the role becomes obsolete, or do you see that on an ongoing way, this role will be maintained no matter how evolved the technology becomes?
I think the role will be maintained for many reasons, and it's because of this kind of unusual, unexpected findings like I showed you with this, and it's gonna be always something new. And the physician will have to be responsible for the scan. Its job will be easier because it will be, it will be aided by these techniques. We'll have as you see, the accuracy can improve. So in my opinion, people have different opinions, but I think physician will be in the loop, physician will be learning, and the physician, especially who learn how to use AI, will be the ones who will stay. And be working very, very. Physicians who don't want to use AI, maybe there will be some problems with that. So.
Amazing. So which brings me to the next question. So how do you think we can address the distrust that you saw in your own study, and something that probably will keep coming up in the future generation of doctors?
Yes, so I think training, showing examples, and I think this kind of like I think what will be that physician can learn from AI, and AI can also learn from the physician as it goes. So it will be kind of mutual process, and I think by just getting used to it, by just finding, okay, it's helpful, by showing more and more studies that it helps, that it, and especially explaining, like to show that it's not a black box, to show like this grad camps, to show these explanations. I think that's how the trust will be built.
Okay, and I have maybe one more question, then we can pass it to Jordan. So when you were presenting the work, you were mentioning that this AI is going to save a lot of money for the healthcare system, but at the same time, we are seeing the emerge of corporate culture in the US, especially in the healthcare. And according to JP Morgan, this in 2023 in the San Francisco report, there's more the corporate world and also in healthcare is more in favor of those projects that generate revenue rather than saving money. So how do you think this aid of AI in radiology and cardiac imaging can generate revenue to make it more stream and translational field rather than something that it is at the moment?
Well, so I think I've shown some examples where we can save costs, like for example, reducing the need for some scans. So I just show one example, but it could be many other examples where somehow maybe even you can use AI to see if the patient actually needs the scan. So you can generate like a more efficient use of resources with AI. If you improve the quality, and images give you better diagnosis, maybe downstream you don't do unnecessary tests, so you can save some money this way. Of course, there's improvement of quality, patient outcomes, and everything, like that people can live longer because of this. So that's a different story. But I think, I think those are the techniques where AI can provide added value. Finding, streamlining, reducing number of scans, getting more out of this. Like for example, this example where from a low quality scan you can maybe get the same information as from a high quality scan. So those are the examples where it could be useful.
Okay, thank you so much, and pass it to Jordan.
Thank you, Dr. Slomka, for the presentation. That was very interesting, and it really broadens our field in terms of how AI and deep learning can be used in medicine. So in this presentation, I noticed that there's a lot of the effects of AI on diagnosis, prognosis. But do you think that AI as a role in medicine can be used more interventionally, maybe in the future?
Well, I think so. It's just not my field right now, but I think potentially, well, it can be used also like what is already used during acquisition to guide, how you do acquisition of the scans. In terms of like robots, kind of doing actually, procedures, I think, I think everything can be potentially done. If the full self-driving is accomplished, I'm sure this kind of things can be also accomplished. But the risks are higher, right? The error, here the error, there's an oversight, so we'll have to think about the oversight, how the oversight will happen. Can the human take over, in a split second and do it? Here, we give a wrong results. Human can look at it and just decide, okay, we're just gonna change it. There's always gonna be this option. So I don't know how this will be in interventions, but I'm sure there are some possibilities.
Thank you for the question. And similar to that for the follow-up, right? How do you see the future of AI can be used in this field?
So I think the future will be first simple things like the segmentations, quantifications. That's gonna be first, and it's already kind of going in there. Already some applications are there because that's a direct drop-in of what people are using. It's not changing the practice. It's just making it faster, making it more reproducible. The next thing will be this this assisted diagnosis. I think we'll see more of it. It's just barely starting right now. I think ultimately the future is to not just to give diagnosis, but to tell the physician or suggest what procedure should be next. Like, so for example, for that patient, specifically for that individual patient, I want that bypass is the best. And for that patient, in cardiology, for example, in radiology could be something different. But to actually recommend treatment, and it's based on some very quantitative values and show the risk and show what happens. So we don't do it yet, but I think in the future you would like to show, okay, well, this is what happens if you do this. If you don't do this, your risk will be so. Let's say I was showing you the heart risk and the heart attack risk, and that's very useful because that tells them that they have to do it. But what physician really wants to know is, like, if you do this procedure, the heart risk will go down by that much. If you don't do this procedure, the heart risk will be that much. And then you can show it to the patient, and patient will say, okay, well, it feels like I want to do the surgery. I think that's where it's going to be more higher end decision support, but we're not there yet.
Thank you so much for that. I just have one last question in this case. Relating to the topic of doctor-patient interaction and how AI can be used in it, do you see like AI can outweigh the benefits of human communication, or maybe it can be used supplementary to when, like, after reading the results, where the doctor can explain these AI images to the patients?
Well, I think people like to speak with people and not with robots. So there was actually, I didn't have a slide here, but there was actually a case in California that, and it was that actually robot told the patient, okay, you're gonna die in a few days, so there's nothing you can do. And there was like so that they actually, the way the media spun it was like the robot came out with diagnosis and tell the patient, but it was actually just physician's report. It was just sent by a robot to the hospital. It wasn't like the robot, but the media said the robot is telling patient that the patient will die, and it was, of course, a horrible thing. And it was on the news, and people said how, without any empathy, this machine comes. So I think we're not going to replace that patient communication. I think patient always want to talk to someone knowledgeable to explain to them all these things, and not talk to some AI about their conditions. So
Thank you.
Yes, thank you, Dr. Thank you so much, Dr. Slomka. I just have one more question, and it's more about the public health point of view. So you showed on your data that at the beginning, especially in some demographics, you overdiagnosed patient, and in fact, it is one of the features that sometimes being housed in healthcare campaign. Beside that, the COVID, that overdiagnosis will tend to decrease the pressure on the healthcare system in some aspect. And for instance, when we think about heart condition, that has the highest amount of the pressure on the healthcare system. Do you think perhaps it's a good idea to keep that overdiagnosis, and in the long term that will return on it, or no? Do you think we should actually get that precision that you were aiming for?
I don't think overdiagnosis is good, because it at least in cardiology, I mean, I don't know what the field, but it can lead to unnecessary and maybe dangerous tests. So an example in cardiology is that if you overdiagnose and you think the patient has a coronary disease, they don't, the next step is to send them to invasive angiography. That costs maybe $5,000-$7,000. That actually is putting the catheter down your arteries. There are risks that you can have a heart attack, you can have a complication during that procedure. So I think, and the other thing is, like, if you start applying some tests in a very large population, and that test is oversensitive for cancer or something, you're gonna be worrying a lot of people, millions of people, for nothing. So I think precision is what we need to get. Overdiagnosis, it's dangerous in some sense. It can be, especially when it comes to screening and all these things, it can just cost a lot of money, especially when it's a public system. Like probably in Australia, like it could put a huge resource burden and without very much benefit. So.
Great. Thank you so much. So we really appreciate your time and your sharing with us your exciting research and journey. And hopefully the next generation of doctors will be more trustful towards AI, so we can all be benefited from the many advantages that this field will give to us, such as what we are seeing at the moment.
Thank you very much. And I'm apologizing again for being late because
No,
there
it's
was
not.
some.
Okay. So much. We really enjoyed it, and again, thank you so much. We are going to, with your permission, we're going to put the recording on our website so our other members can see it as well.
Okay, thank you very much.
Thank you very much. Thank you.
Bye.
And consideration.
Bye for now.
Thank you so much, Professor Slomka. Bye.